Now, the promise of excellence and quality fertility care at GFC is a commitment that we owe all our patients. All right, we are trying to ensure that we offer quality healthcare services, particularly fertility care. That is one of our flagship, and that is the majority. That's the reason why most of our clients come. They have a very strong desire to be able to fulfill that reproductive right. Why? Because every couple should be able to reproduce their kind. So that is one singular right that God has given to every one of us. Unfortunately, in the day and age where we live, that is becoming more challenging. It has always been the case of infertility, has always been with us from the very beginning, even in the Bible. It was there. Some women were barren. But we find these days that the number is increasing. But the good news is that God has made a way and has provided the wisdom to ensure that those who were term barren before will not end up being barren, but that after a while, they will become fruitful couples. All right? But we believe to be able to provide you, our clients, with quality care and to serve you better, we must empower you with knowledge. We must empower you with knowledge. You must know the process. I don't know if you know about our own personal journey. We waited for 12 years, went through infertility treatment for 6 years, did nine IVFs. By the time we were done, my wife became a doctor. She could sit you down and talk to you. Somebody who didn't know her would think that this is a doctor speaking, and not just a doctor, a specialist. Why? Because she knew so much, because she was part of that process for 6 years. She was so empowered with knowledge. And so for us here, we want to empower our patients, not just for your own benefit, but so that you can also help others. Because most of the clients that we get are all based on personal referrals. People who have been blessed and they share their testimony and they share their joy. And those who are also trusting God will say, what happened? Where did it happen? What was your journey like? Say, oh, go to this place. And it's not just that you say, go to this place. You can also share your own experience and the knowledge you have gathered. I have one of our patients who delivered a set of twins, and she now became a counselor. Patients will not ask me questions. They'll be calling Hadiza. Hadiza, hey, when you went through this, how did this happen? What did you do? I said, what is happening here? Hadiza said, doctor, relax. You have to pay me for this job. Bro. I'm now your second. Exactly. So she was now counseling them and talking to them. Why? Because she was empowered. She knew a lot. I know you are often confident with someone who has gone through the road that you are going through and have experienced what you're probably going to experience or you're experiencing. And when they speak to you, you are more confident. So we believe that for all of our patients who go through this process with us here at the GFC, they would be empowered with knowledge. It's also very important for your own treatment. All right, for your own treatment. I believe that the treatment you get here must be participatory. You must be involved in it. You should be asking questions. No, we don't believe just follow what doctor says. Once they give injection, don't even ask, no, what injection am I getting? What is the dose of this injection? What the doctor said is this. Is there the right dose? Now, we have a patient who took Zoladex injection. We'll come to that. For some of you are wondering what is Zoladex injection. It's given to patients who are undergoing a recipient program, donor program. And after 28 days, that injection will elapse and you'll continue with the daily injection. They are both general analogs. They downregulate your system, take over your body system so that your body doesn't have any input, so that we can be able to control your system. And so this patient had finished, the Zoladex had expired, and she had started the buserelin. She took the first dose, and then she didn't come again. For 6 weeks, almost 1 week, she didn't come. What happened? But it was when we did the first examination and it didn't go well. We were trying to just see how we can sort out. That we now even realize that this woman has not been on injection. She took the first one and she stopped. He said, nobody told me to come again. And funny enough, this woman had done this similar program, had similar injection, and got pregnant before. And this time I said, I thought program has changed. How will program change? What am I saying? If she had enough knowledge and knew what the process was, she wouldn't have taken that kind of decision. All right? Even when information is not coming, you're not being reminded, but you know that this is what should happen. It was better she said, I'm supposed to come tomorrow, right? Because this is what happened before, than to assume that, oh, maybe program has changed. All right? So we expect you to know the process so that you know what to expect. And if it's not done the way we have said it, you should begin to ask questions. Now, this platform will also provide you an opportunity to ask questions. I'm sure all of you will have questions, because during the clinic sessions, you may not have enough time to ask all the questions you want to ask. In fact, sometimes when you are there, all the questions will just fly. It's when you leave the consulting room and you get home and say, I forgot to ask doctor this question. Kai. Now, this is not a clinic, so I want to assume that those questions will still be with us, so we can ask the questions. And then we clear all doubts. So the plan is to concisely lay out the IVF process that the client will go through. Now, as much as possible, next slide, as much as possible, we will try and go through a summary of every bit of it. Now, you need to understand that no two clients are going through the same program. So we have women that are seated here. You don't compare yourself with another. Say, hey, this woman took injection at this time. I've not taken that injection. Ask, is she going through the program you are going through? So we don't compare. So I often would want to discourage that, okay? So it's important for you to know what program you are going through and then ensure that the program is going well as planned. Whether a program will succeed or not depends on a lot of factors. But what we have promised our clients here at the JFC is that we will do what is humanly possible to ensure that we have done our best. All right? And then we leave God to decide. Whatever it's humanly possible, scientifically possible, the best option, the best treatment option for you, carrying you along, we would provide. So I'm sure a lot of us have gone through this phase already, but usually we'll put it there so that you know what the beginning is like. Because at the beginning, you would have gone through registration and your consultation. How many of you have not had consultation before? Just appeared and all of us went through an initial consultation with a doctor or with a nurse. And then you went through investigation. How many of you have not gone through investigations? You've not been to our lab. If you've not been to our lab, that means that you are just at the beginning. That means you just had registration and had the first consultation. Because after you've had that first initial contact, the next thing is that you will go for your investigations, both the male and the female. Oh, doctor, what if I've done all my tests outside? Can I just bring the sheets and then you just take off from there? Not really. Why? Because we want to have our own documentations. They're all very important to us. And again, just in case there's some error somewhere, we don't follow and take what somebody else has done. So you'd have had your investigations done, and then you'd have had your result review. Because after you've had your investigations, we would do a result review with you. Result review section, it's an opportunity for us to tell you what your results are, interpret the results, and based on the results, tell you what the treatment options will be. And right there and there, we would decide what the treatment option that will be best suited for you. Okay. And so once the treatment option has been decided, based on the treatment options, you will know what payment plan you have. Payments are done, and then the program begins. Okay. Now, for patients who are not based in Abuja, I'm sure there are many of them who are online listening to me right now. Please make sure that if you are not in Abuja, we can have the result review done online. You have a consultation scheduled for you, and then the result review will be discussed, and the treatment option decided. You need to know why we are picking the treatment option that we are picking. For us here, as a general rule, we try to teach or pivot towards an option that gives us the best results. Sometimes it may not be the most convenient or what the patient would want, but based on scientific evidences, because for us, you didn't come here to try IVF or to try treatment, you came here to get pregnant. And for us, for us is the major priority. We want to try and ensure that at the very first treatment trial, you have a very good chance of achieving that. But what we do is that we will give you options. We don't say, oh, it must be this. No, we will give you the options and we will tell you why one is superior to the other one. And then what are the pros and the cons. All right. Next slide. Now, once you've had your treatment option discussed with you, every patient that goes through a treatment program must have a plan. How many of you have gotten a plan? How many of you have not gotten a plan? Okay, you've not reached that level. That's why you've not gotten a plan. Every patient on a program here must have a treatment plan. The treatment plan comes after the discussion. Your treatment options have been discussed with you and we've agreed at what treatment option you're going to be going through. And so, what is the treatment plan? It's a sheet of paper that summarizes the process. There are dates in that plan, but the dates are very tentative. All right? And then, but it gives you a guide. It's actually a guide that guides you through the process and hopes to tentatively give you a date for your transfer, date for insemination, date for pregnancy test, date when you will have your injection started, when you will see your period, when you will start down regulation. All of those key important steps during your program will all be highlighted on that treatment program. All right? And then you'll be given. It will be explained to you. So for those who are in Abuja, we often will encourage them to come to the clinic and meet with the nurses to have a physical one-on-one discussion so that it is very clear you have an understanding of how your program would go. For those who are not in Abuja, we will send the program to you. Program is sent to everybody. It will be sent to you, and then we will try and have a conversation with you, whether a phone call after they've sent a voice message to explain to you what your program is all about so that you have an understanding. Next slide. Okay. Then after that, the consent form will be signed. Everybody going through a treatment program, you must sign a consent. You must give us a consent. So again, with a show of hands, how many of you have signed a consent? Let me see your hand up. Okay. Those who have not signed, you have not reached that level yet. Or you passed and they did not ask you to sign. You passed. Wahala. Ma'am, what about you? Okay, you yet to submit. Please try and submit it. And please, for no, sister, take note. Everybody must sign the consent. They are all different. There are different consents, or they are different. So based on the program you're doing, you'll be given a consent form to sign, and that is what authorizes us to go ahead with the program. It also tells us that you understand what the process is all about, because you're supposed to have the counseling concerning your program before the consent form is signed. All right, so next slide. Okay, menstrual regulation. Most patients who are going through treatment programs, you will go through what we call a menstrual regulation. And what is the essence of this menstrual regulation? For some patients, it is part of their program. We need to regulate their cycle, all right, to make sure they see their period at a particular time. And for some of them, during that process of menstrual regulation, it also helps to down-regulate them. It also helps us to take over their body system. So it's part of the treatment that they are going through. So there are medications we use. So basically what it means is that you're just taking medications for some time to see your period at a particular time. And medications that they're given differs. Some will have the levofemide, which is an oral contraceptive pill. Some will have Primolut N. Don't say, why did that patient take Primolut N and I did levofem? The reason why we do that is based on your profile. All right, like I said before, no two patients are the same. All right? But let me state here that there are some patients who will not be given or asked to take any of these menstrual regulating agents. Why? Because also of the kind of program we are running for them. Okay? And so you'll be told when to start and when to end. And you'll be told this is how long you have to take it for. And please make sure you take your medications as prescribed. So, doctor, for 2 days, I forgot. I was so busy in the office when one pressure here and there. Please, I know that can happen, but let's try and avoid such happening, okay? And so the process of down regulation is done with the use of medication. All right, so virtually all patients will go through the process of down regulation. And what does it mean? It means that we are attempting to take over your body system so that your body does not react or work that way. It will interfere with our own process. For example, if we're stimulating a woman, meaning that we're giving her injections for her ovaries to produce eggs, we don't want those eggs to be released before the time they are supposed to be released, because we want to be able to determine when the eggs will be released. If she's not on any form of down regulation, by the time we are ready to collect our eggs, those eggs would have been released. And sometimes we do find 1 or 2 occasions where, in spite of the down regulation, the body still was able to just release some of the eggs. All right? So that's the importance of the down regulation. Or for women who are on egg donation program, they also will have down regulation. Why? Because we don't want their body system to go and ovulate, produce progesterone, and then we miss the window of implantation. So down regulation is very important. However, there are some women who will not go through down regulation. And the question is why? Yes, the reason why they will not go through down regulation is because there's, sir, please, there's seats in front here. Welcome. Now, the reason why they will not go through down regulation is because of their age, or because they are no longer menstruating. If a woman is no longer menstruating because of age or because of some other factors, then we are not scared. Why? Because the ovaries have stopped functioning. So let me put it this way. A woman whose ovaries have stopped functioning will not need to go through down regulation. Okay? And so again, like I said, a woman will say, but nobody gave me Zoladex. Yes, nobody gave you Zoladex because you didn't need it. Okay? You didn't need it. All right. And so, but for those who would have, they are sitting in front, please. Ma'am? Yes, in front. The light will not affect you. I want to be seen. Come to the front. There are seats here. These seats are for you. They're not for VIPs. You're all VIPs, so you're all the people we have been waiting for. All right, you're welcome. So down regulation can come in different forms. For those who are going to be stimulated, meaning that we are using their eggs, they're going to be taking injections. They have different protocols for down regulation. So just note that it may be different. Please, let's put all our phones on silence. Thank you very much. All right, so I was saying, for those who are going to be stimulated, there are different protocols for down regulation. There are some down regulation that will start on the same day that you start the stimulation, taking injections to stimulate your eggs, your ovaries to produce eggs. And that is the agonist protocol. And there are some who would use the antagonist protocol that will start some days after they have started the stimulation. I expect you to know which protocol you're on. The doctor will tell you whether you're the agonist protocol or the antagonist protocol. And after some time for the antagonist, the second injection will start. But for the agonist, the two injections start almost about the same time. All right? Again, why we use different protocols depends on different patient's profile. All right? Now, for those who are recipients who are on egg donation program, the down regulation is taken with one injection, which is a depot injection. Depot means that it is given once, but can last up to 28 days. You don't need to take it every day. And it's given on the tummy. That particular injection is a bit, let me not say that one, so that I don't want to scare people. Yes, so you take that injection on your tummy. So for all patients who are going through the recipient program, you will be given that injection, except if we have said you don't need it. So you will not have it. Okay? And once you take that injection, you'll be told when that injection will expire. Like I told you before, that was what that patient took. And she was told when the injection will expire. And she was even called. And she came to start, and then she didn't come again. All right, so you need to know that that down regulation must continue until the day of insemination. Day of insemination means the day that the spouses will come, produce sperm to fertilize the egg, and thereafter the progesterone will start. So it will continue to take that injection. Sometimes the duration of this injection cannot be predetermined, particularly for those who are recipient programs. But as long as you're taking that injection or that injection is still working, we're in control. But once we stop taking the injection, then we lose control. So these two names will be very familiar with us, and those are injections that you'll be giving for down regulation: Zoladex and buserelin. Okay? Zoladex and buserelin. It's important that you know these names. Zoladex and what? And what? Buserelin. The Zoladex lasts for 28 days. It's one injection, and It can last for 28 days. The buserelin is a daily injection that is given. Okay, so once the patient sees her period, next slide. So either stimulation would start or endometrial regeneration. Stimulation for those whom we are using their eggs, or endometrial regeneration for those who we are going to be building up their womb to receive embryos. They're on recipient program. Now, for those who had been on menstrual regulation, once you stop the injection, the medication, you are told that 3 to 5 days your period will come, right? More than 90% of patients will see their period within that. But however, there are some patients whose period will delay 7 days. They have not seen it. Don't call the nurse or the doctor after 1 day of stopping the medication. I say, doctor, I've not seen my period. When did you stop taking levofem? Yesterday. I'm not supposed to see your period. Relax, be calming down. All right? Don't fret. It's 3 to 5 days, maximum 7 days. After 7 days to 10 days, if you have not seen your period, then you can call the nurse or the doctor that, see, I stopped taking levofem so and so day. It's been 10 days now, and I've not seen my period. Then we'll ask you to come, and then we'll take it off from there. But like I said, more than 90% of patients will see their period. And so once you see your period, what are you asked to do? Excuse me. You are asked to book an appointment. Please, once you see your period, some of you have not gone to that stage yet. Some of you have already passed that stage. All right? Just giving you the process. Once you've seen your period, call the front desk and book an appointment. When you are asked to call the nurse will tell you, call the front desk and book an appointment. So what I'm saying is that the next thing to do after you've seen your period, after you have taken the menstrual regulating agent, or if you didn't take at all, once you've seen your period and you're already scheduled for a program, you have a plan with you. Once you see your period, book an appointment to come to the hospital the next day. For patients who are going to be undergoing going through stimulation, 2 to 2nd or 3rd day max, your stimulation should have started. It's very important. If you've seen your period and you come on your 4th day, we won't be able to start your stimulation. Yes, day 2, day 3 will start. For patients who are on endometrial regeneration, well, that one is a bit more flexible. Even if you don't come on day 2, day 3, day 4, for some reason you forgot or you are not even in town, and you don't tell us once your period comes, we will still be able to do something with your cycle. But for patients who are going to be going through stimulation, you need to let us know and book an appointment to come in to start your stimulation or endometrial regeneration. Next slide. Now, that scan is a unique, appointment is a unique appointment because you're not just coming to just start your stimulation or start endometrial regeneration. There's one important thing that will be done for you, and that is what? Those who have done it before. Mock, correct. Mock embryo transfer will be done. So if you go through this program, and you've not done a mock, then we've missed that aspect. So again, with a show on how many of you have done mock? How many of you have done mock embryo transfer? Okay, that means somebody has not even gotten to. The reason why you've not done mock is because you have not gotten to this stage, right? Now, if you've not gotten to this stage, no problem. But on this first appointment, when your treatment starts, a mock embryo transfer must be done. And what is the purpose of the mock? The purpose of the mock is to ensure that there are no challenges with access into your womb. So we want to make sure that there's no cervical stenosis, that there are no challenges, that we can be able to transfer the embryos. Everything that is done on the day of transfer is done, except that we don't have embryos. That's why it's called a mock embryo transfer. And we will determine your length and take measurements and know exactly where the embryos are going to be dropped. It's also important for you to note that this is done in the clinic, usually. But sometimes, for some patients who will have difficulty accessing the service, it will have to be done in the theater. And if it has to be done in the theater, terms and conditions apply. I'm sure you all know what terms and conditions means. Some additional things that accompany will have to drop for that phase. Now, all of these things are things that I explained to us when we first get started. That is why the total cost in terms of package, you cannot say this is what it is exactly, but we'll give you a range, because there are certain things that we may not know that may happen that will attract an additional cost. One of it is if you have a mock done under anesthesia. All right? And so once the mock is done and everything goes well, you do a scan, just for those who are on stimulation to be sure they don't have a cyst. If there is no cyst, then you go ahead and then you start your stimulation. If there is a cyst, then there's a decision that has to be taken, either to move the program by 1 month, place you on medication to see if that will help to remove the cyst, or we drain the cyst by taking you to the theater. Again, if we have to take you to the theater to drain the cyst before you start the program, terms and conditions will apply. Now, this is something that is not for everybody. So it depends on if there's a cyst found. All right? And so once we've passed that stage and everything is fine, then you start your, your program. There are medications that are, excuse me, there are medications that are prescribed to you at the beginning of your program. Please make sure you get the right medication. You will have antibiotics given to you. We give antibiotics to both couples. Why? Because we just want to be sure that there's no infection that will interfere. And then you're giving the routine hematinics, folic acid, aspirin, vitamin E, given to you. And then for those who are for stimulation, you are giving your injections that you take. And for those who are on recipient program, you are giving oral medications to take to build up your womb. And then you come in for regular scans. So for those who are for stimulations, next slide, you have about 5 to 6 scans. So you have the first scan done on that day 2 or day 3 of your cycle. Then the next scan is on day 5. You are told when you're coming. So please, when you finish, ask, when is my next appointment? When am I coming next? You must get the date, and then you must book that appointment with the front desk. Don't just leave. All right? Please make sure you get an appointment for your next visit before you leave. And so for patients who are on stimulation, they'll be seen on day 1, day 5, day 7, day 9, day 11 of stimulation, which will equal to either day 2, day 6, day 8, day 9, day 10, and day 12 of their cycle. And when you come for this appointment, you're going to be scanned. The essence of this scan for patients who are undergoing stimulation is to ensure that your ovaries are responding well. We'll take measurements. So you see the doctor will do the scan, and then they will measure the follicles. They want to count the number of follicles you have, and the size of the follicles, whether they are growing. And the reason why we need to do this is to determine whether we need to adjust your dose of injection that you're having. Okay. So you keep going. What is the target of this stimulation? Here at GFC, we usually do an average of 12 days of stimulation, minimum 12 days. No matter how well you're doing, we'll get to 12 days. Why? Because we want to try and ensure that as many follicles are matured as possible, as many eggs are matured. And for us, what determines maturity is the size of the follicle. And so we'll look at the size, take vertical and horizontal measurements, do the average. Once we have 3 follicles that are more than 17 mm in diameter, and that means that we are there. But we don't follow, this is what textbook says, but we don't follow this one. We want to make sure all the follicles go beyond this 17 mm. Because if a patient has 10 follicles, and only 3 of them are 17, and you take her to theater, and out of 10 eggs, only 3 are matured, would you be happy? No, patient will not be happy. So we extend. So sometimes some patients may do 13 days, some may do 14 days, some may even get up to 16 days. What are we trying to do? We're trying to ensure that we get as many eggs to maturity as possible. Next slide. And then once we get to that point where we are sure, or at least the scans are suggesting that these eggs should be getting close to maturity, you will now be told this is when you will have your last injections. Now listen, for those who are on stimulation, your last 2 injections are timed. They are given at specific times. And the nurses will tell you these are the times you should come for the injection. The last HMG and then the trigger injection. That is the HCG, to bring about the final maturation of the eggs. Okay? And so it's important also that for patients who are undergoing stimulation, on the day of that trigger, you do your progesterone test. Very, very important. The reason is because we want to know what the progesterone level is on the day of trigger, because it helps us to prognosticate your outcome if we go ahead with a fresh transfer. Because if the progesterone level is high, beyond a certain level, then your chance of achieving conception will be reduced, because it will be difficult to get your window of implantation. So we will do that, and it helps us to determine whether we should freeze or if we should go ahead and do a transfer for you. All right. Next slide. So, like I said before, you'll be started off on injection. For those of you who are on the agonist protocol, you will start 2 injections about the same time. The folliculin, which is what we use, which is the highly purified FSH, and then the buserelin. We're giving on your tummy. The dose is determined by your profile. In fact, by the time you make your payment, you already would have known what dose you are using, because it's also determined, it also determines what you pay. We don't have, well, for those who came into the foundation, the foundation program is tailored such that you only pay for what you use. So if a patient is on 150 IU, your cost is different for someone who is on 225, than for someone who is on 300. So you don't come and say, MD, people don't like me in this place. So my friend that I even brought, look at how much he paid. And we are doing the same program. Me, I paid double. How? I'll say, calm down. Did you ask your friend the dose that she's using? No, I didn't ask her, but we are doing the same program. It's not the same program. The dose is different. So the cost you pay depends on the dose that you're going to be using. And then you'll be told, if, for example, you're starting with 150, and you don't respond to 150, and then we need to increase that dose, you'll pay the difference. All right? And so I'm saying it here so that the complaint that patients have, they say, oh, I was not told. Just in case you were not told, I'm saying it. So you just get ready. All right? Standard dose is usually 150 to 225. But some patients may not respond, and then we need to increase the dose to 300. And so you just get prepared to just make the additional cost if we have to do that. So we use both folliculin and UMOG, which is the HMG for stimulation. Next slide. And then you come for your scans, and we see the ovaries, the follicles grow. You see the word, we use the word follicle, and we use the word ovary, and we use the word egg. I'm sure you don't understand what this all means. All right? You see this? Those who are going through stimulation, excuse me, you will see your ovary look like this at certain points, right? At certain points, your ovaries will look like this. This ovary is now big, it's now enlarged. These are what we call follicles. This round black stuff are what we call follicles. They were initially very small, and these follicles contain eggs. So there's an egg here, 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 egg, that. So depending on the number of follicles we have, that would determine how many eggs we're expecting. So in the clinic, we'll tell you that, oh, we have 6 follicles on one side and 7 on the other side. That is how many? That is 13. So we're expecting that's the number of eggs we will get. Sometimes it doesn't exactly equal that. All right? But it gives you an idea as to the number of eggs to expect. So when you are doing your scan, ask your doctor, how many follicles do I have? They'll tell you, okay, on the right side, you have this number. On the left side, you have this number. On the day of retrieval, this is what we are going to be retrieving. So we'll drain. This follicle contains fluid. It's just fluid that is here. When you see anything in scan that is black, it means it's just fluid. So we'll drain this, drain this, drain this, drain this. We'll drain everything. And as we drain, the egg will come with it. And then we'll take what has been drained and send to the embryology lab. And the embryologist will screen it and then pick out the eggs out of the fluid and then discard the fluid. So what is the aim of this stimulation process? Is to ensure that we get matured eggs. Not just eggs. But what? Matured eggs. Why? Because if the eggs are not matured, there will be no fertilization. Very unfortunately, we've had very few incidences where we've gone through a program and then we retrieved eggs and none of the eggs were matured. It doesn't happen often, very rarely. And sometimes you're asking yourself, what happened? How come this woman produced eggs and the eggs were not matured? Because if the eggs are not matured, then that program is as good as coming to an end. So the goal, so when we're increasing the days of stimulation, don't say, doctor, more injection. Please bear with us. What we are trying to do is that we are measuring the follicular size, and we're saying that, you're not there yet. You're supposed to be this, but this is what you are. Let's try and increase the number of days of stimulation. And so you understand why we say, if you're not responding and we need to increase your dose and therefore increasing the number of days, terms and conditions will have to apply. Because it means that we are going to give you more medications, okay? Why? Because we want to just ensure that we get the best. Next slide. So once we are able to do that, like I said before, 12 days stimulation is what we normally do, minimum. And then you are giving your last HMG, which should be 24 hours before your trigger. And then your trigger is 36 hours before the OCR. So what that means is that if you take your trigger 7:30 p.m. on a Saturday today, When are you having your collection? 7:30 a.m. on Monday. It's all timed. And so if you are given a time to come in for your injection, please make every possible arrangement to ensure that you are here on time. All right? And then you're giving. Now, the only last, so the buserelin, which is the medication for down regulation, you keep taking it until the last injection is given. And which is the last injection? Which is the last injection? I want to know if you are following. ACG, correct. That is the last injection. So when you start injection, you keep taking injection until that last day when you take your ACG in the evening. And then that day you also will take buserelin too. Sometimes you can take it earlier before the ACG. The only day that you have free is the day after ACG injection. That is the only free day. You're not coming to hospital. We don't need you. We don't want to see your face until the day of retrieval. That day is free for you. All right? No. The ACG is only for patients who we are stimulating, whom we are using their eggs. They're the only ones that take the ACG. They're the only ones that take all of these injections. Why? Because we want to stimulate their ovaries. For those who are not using their eggs, for the recipients, they don't need all of these injections. Somebody else, we're getting the eggs from somebody else. All they need to take is just that first injection to downregulate their system. The next injections they will be taking will be the progesterone injections to prepare their womb for embryo transfer. Okay? And so that is what is done. Now for ER, that is endometrial regeneration. So patients, basically, like I said, you're not taking injection. What you're taking is oral medications, all right, to build up your endometrial womb. The estradiol valerate, 3 times a day, 1 tablet. And the target is to get your womb to be at least 7 mm. What did I say? 7 mm, the least. So once we get 8, 9 and above, you have already passed. So we just tell you, okay, no more scan for you. Just continue with your medication. And this is what we expect to see. You see this, what we call a triple line echo? Can someone see the 3 lines there? Can we see the 3 lines? Which are the lines? This, and this. Now, once you have this kind of endometrium, you're happy. Because when you put a very good embryo into this womb, the patient very likely will get pregnant. All right? And so once you do the measurement and it's above 7 mm, then that means the patient has done well. Again, for patients who are on endometrial regeneration, usually 14 to 21 days is the length of time that is needed for them to be able to build up their womb sufficiently for them to have a transfer. All right? To have a transfer. So for them, their scans are not as frequent as those for stimulation. Why? For those for stimulation, they come first day, 5 days, 7 days, 8, 9, every other day. For them, just weekly scans. All right? Just to see how their womb is responding. Next slide. Okay, so OCR, for patients who have gone through ovarian stimulation. The patients who are for ER, who are recipients, will not do this because we're not collecting their eggs. All right? But patients who have gone through stimulation would have to come to have the collection done. Like I said before, it's usually done 36 hours after they've had their last injection. It's usually done under anesthesia. So patient will come fasting. The nurse will give you all the instructions to follow on the day of your last injection, the do's and don'ts. All right? You're not supposed to come with perfume, no deodorant, just take a bath, couch, come fasting. and then we collect the eggs. Like I said, it's done under anesthesia, so there's no pain. But after the retrieval, you may feel some soreness, and the pain you will feel depends on the number of eggs we collected, or rather the number of follicles you had. For patients who are polycystic, if you have been told that you have PCOS, and that means the number of eggs, follicles that you have is a lot, and those patients, after the transfer, they may experience a lot of bloatedness, pains, but we're able to manage all of that. So that is not a challenge. And then after you've had the egg collection, you must start your injections, the gestone injections, the progesterone injections. If you have had an egg collection and they didn't give you an injection, ask the nurse, I'm supposed to take gestone injection. I was not giving. Why? I agree that for some very few patients, they may not be given, but you must be told why. Who are those patients that may not be given? Anybody can give a guess? If we didn't see any egg, are we going to give it the injection? No. Why? Because that injection you take for 6 days is what prepares your womb to have a transfer. So if there were no eggs, and that means that there will be no transfer. So we will not be. Or if we have already determined that we're going to freeze the the embryos that will be generated, in which case we are not doing a fresh transfer, then you will not need to take the injection. But most people are started on gestone, even for those who we think that we may freeze their embryos. They start it. And the reason why they start is because we want to be sure that on that day we're not caught unawares. What do I mean? Yes, we may be thinking that, okay, this patient is at very high risk of having OHSS, and so our level of progesterone may be very high, okay, and that will compromise our endometrial receptivity, and so very likely she will not have a transfer, and so don't give the gestone injection. But the reason why we still going to give and have an open mind is because plans may change. And what will make those plans change? If, for example, the progesterone level turned out to be okay, or the OHS was not as bad as we thought, or the embryos that were generated, the quality does not qualify for those that can be frozen. In which case, in that scenario, it is better to have those embryos transferred back into the womb. If that womb have not been prepared to receive the embryos, then that will become a challenge. You understand? So I said that to say that there are very, very few reasons why you will not have that injection started after the retrieval. So once it's not given to you, please draw the attention of the nurse, okay? And so after you've had your gestone injections, and for those who are recipients, yes, you're not having egg collection that day, but your husband must come on the day of insemination. That day means that we have eggs for you from a donor. We need your husband to come with sperm so that we can inseminate and generate embryos, which we will transfer. While I have said for patients who had egg collection, the gestone injection starts on that day. For patients who are recipients who had insemination, their injections does not start that day their husband came. The injection will start when? The next day. Doctor, why? It's not the same. Why is our own starting a day after? The reason why we start injections for patients who are recipients a day after is to be sure. We want to be sure that we have fertilized eggs and that these patients are going to go ahead and have a transfer. Because for those patients, when they start progesterone is what commits us. And means once they start progesterone, that means that 6 days, 7 days later after, we must have a transfer for them. And so when we collect the eggs and we do the insemination, we want to be sure, because after 18 hours, we will know if there was fertilization. Just in case there was no fertilization or something happened, if we have not started that patient on progesterone, we can move the patient program forward. It means the program has not come to an end. We just extend it, and then we do another insemination. Before we are doing same day, you start your injection, just like the patients who go through stimulation. But we discovered that for some patients who there was issue with fertilization, that program just ended there because we couldn't salvage that program because there was no fertilization. So for patients who are recipients, once your husband comes, be expecting a call the next day. If they don't call you that day, call the nurses. What am I saying? For patients who are on recipient program, expect a call to start gesto. Don't go and start by yourself. See, the MD said it's the next day, and so they gave you your gesto injection. You're not in Abuja. I say, oh, honey, okay, you're giving them this pen. Okay, the next day, oh yeah, nurse, come and give me injection. No, you must wait for instruction from the nurse to start the injection. Once you are asked to come and start gesto, what does that mean? It means that you have fertilized eggs, which are growing, that will end up becoming embryos. Okay? So for our GFC, we do our transfers 5 days after the egg collection or insemination. 5 days, not 2 days, not 3 days. Those are the other days that transfers can be done. If we elect to do your transfer after 2 or 3 days, it means that there was a peculiarity to that program. Normally, it's for 5 days. All right? I'm sure by now you should be able to determine the day your transfer will be, all things being equal. If we said 5 days is, after 5 days is when you do your transfer, whether it's egg retrieval or the day your husband came for insemination. So let's say, for example, today is the day that egg retrieval was done, or your husband was called to come and produce sperm. When will the transfer be? Let me see somebody here who has. When? Which is when? On Thursday. Correct. So you already know that Thursday is the day your transfer will be, right? But the time you will not be told. Your time for transfer will be told not a day before, but on the day of your transfer. That is when we will know when the transfer will be. Again, why is that so? Because on the morning of the transfer, the embryologist will check the embryos based on the culture that we do. You know, these embryos, they're inside an incubator and they are culturing, they are dividing, they are growing. We don't go there to check them every day. Let me see how Yemi's embryos are doing. You go there, you bring them out, microscope. The next day, this embryos, let me even see how far. If you are bringing out those embryos every day like that, they won't grow well. So we do a continuous culture. So once they've done the fertilization check, and then they've changed the dish, the embryos are kept from the 3 up until the 5. Nobody opens that incubator to check anything. So the first time that we would know how your embryos have truly done, how they have truly fared, is on that morning of the transfer. And so the embryologist will check, and then we'll see how the embryos have fared. Sometimes if we do a late work in the lab, maybe we did embryo transfer that extended late into the night, the embryologist can just give a peep into can just check one of them just to see how they are doing, to have an idea as to when likely transfer will take place. Most times they do it on that morning. And so once they do it, they're able to tell us that, see, this patient, call them now. Why? Because these embryos they're on fire. They are doing very well. They are already blessed. Some of them are even about to hatch. Please, we have to do this transfer in the next 1 hour. And so sometimes you see the nurse will give you a call and give you a very short notice as if they are hurrying you. Please don't get angry. It is just the way your embryos are behaving. They need to get back into your womb, sharp, sharp. But there are some that is okay, we can do this transfer in the afternoon. Some will say, these embryos, we still need to give them time. Let's wait till later in the evening. All right? So what that means that I don't expect a patient to send me a text and say, sir, my transfer is for Thursday. Nobody has told me when my transfer, the time for my transfer. And he's sending me this text a day before. What have I said? Nobody will tell you. Because we don't even know. Okay? So on the morning of that day of your transfer, you'll be told the time, and then you'll be expected, next slide, you'll be expected to come into the clinic at least 30 minutes before your transfer. Again, patients would have been counseled on the do's and don'ts. And then the transfer is done. Transfers are not painful. In fact, the experience we've had is that most patients, they don't even know when the transfer is done. They're expecting, I don't know what they're expecting when they're coming for embryo transfer. Have you done it? Yes. It's done. All right. So it's not usually painful. But do some patients, depending on their threshold for pain, may feel a lot of discomfort when the instruments are being put into their body. All right. So after the transfer, you come out of the theater, you walk. In those days, we need to carry them on a stretcher, but we don't do that anymore because it's of no use. 5-10 minutes after, you can get dressed, and then you can be on your way. Can I drive after an embryo transfer? Yes, you can drive. But if your husband is around, oh yes, you can drive. But if your husband is around, husband, please, except you are not in Nigeria. Anywhere you are in this country, your wife is doing transfer, you must show. I'm sure the men here, they're all very, very supportive. Don't say, oh, there's one, whatever business transaction, make sure it has been concluded before that day. Before that day, you bring your wife to the hospital, you wait. Sometimes there may be some delay, you wait. She finishes and then she comes down, and you carry her and then you take her home. Is that okay? Must I stay in the hospital after the transfer to rest? Not necessarily. But if you think that your home is not conducive, that you need a very quiet place just to relax and just have moments, why not? We have very wonderful rooms that you can speak to the nurses, and once terms and conditions are agreed. You think you speak before? Yes. Terms and conditions must apply. All right, then you can come and do your bed rest here. Do I need to stay at home for 2 weeks after this transfer? Should I stop work or take leave? Not necessarily. Oh yes, you don't have to. See, it's not physical activity. It's not physical activity that affects the outcome. It's psychological. And trust me, if you're not doing anything, that stress will be worse. You'll worry more because there's nothing to distract you. Doctor, can I climb stairs after transfer? Yes. The thing will not fall. It doesn't fall. Where after transfer, where you do your transfer is not on the ground floor, it's upstairs. For those of you who have not had transfer before, it's upstairs that we have the embryology lab. Oh, okay. Descending and ascending are different. You see when women, after transfer, when they're coming down like this. That's the one that's things happening. No, doctor, no, I don't want any story that all you have. I must take it easy. It's okay. So it doesn't help. But please, at this time, our spouses must be very supportive. Must be very, see, you must understand that your wife has been on hormones. And what hormones do sometimes to women, it differs. That's the only time you now start picking quarrel. Hey, that is the worst time. So even if she did something, say, yes, ma'am. Oh, go and get this. Yes, ma'am. Oh, I want this. Yes, ma'am. Okay? Just make sure. Please, very important. Make sure you pet them. That 2 weeks, please, no issue at all. The woman must be happy. Must be happy. She says she wants to eat shawarma. I say shawarma. Okay, go and get shawarma. Say, no, this I don't want this one. The one that they do in this place, that's the one I want. Bottom line is that let's ensure that we avoid anything that brings about any worry, psychological stress. So let me tell you what stress does. When you're not happy, when you're stressed up, your body produces hormones called cortisol. It fights and negates the implantation process and all the other hormones that are in your favor. All right? And so that is why we don't want, above all things, it's not the physical activity. Oh, you are going to work, you are driving. After all, women get pregnant and they don't even know they're even pregnant. So it doesn't affect. The one that affects is stress, worry, that affects you psychologically. If, however, your job is affecting you psychologically, then you can take a break. All right? You can take a break and then all will be fine. Lots of fluids, lots of vegetables. Just ensure you eat a healthy, your diet is balanced and is healthy, okay? And have plenty of rest. And then no sex. Yes, so no sex. For that 2 weeks, no sex. And it can prolong. So I need the men to understand now. Don't say, you are just overdoing this thing. Is that what doctor said? So let me state what it is for avoidance of any misunderstanding. Once you've had transfer, we avoid sex. Then 2 weeks after, by the grace of God, you get pregnant, that embargo is extended for another 2 months until you are about 3 months. And then when you now do your cerclage, because a lot of people will have cerclage. Cerclage is you tie the neck of your womb, just to ensure that we don't have issues of miscarriages at mid-pregnancy for those who have not carried a pregnancy before. But once we do that, the embargo increases for another 2 to 3 months. So that's like you get to like you're about 5 to 6 months ahead. So if the woman now still feels that there's still opportunity, but if not, if the woman says, man, just be on your side, let me just till after delivery. That is how many. That is the way. That is the way it is. But you know, this is there now. You cope. Anyhow, you cope. All right, so, and then avoid potash, in co-op B, all those people that like to do all those goat head and all of those things, abacha, please, let's avoid, yes, for the women, you avoid potash because it's not good, okay? So, for those who are in Abuja, you book an appointment to see the doctor, to see the IVF team 14 days after your transfer. We like to do that test and see you in the clinic. It's not as if you couldn't have done it at home and just know what the result is. Although some people, they cheat. They'll just be checking that thing and just know what it is before they come. They'll just be pretending. I know once they come in like that, I know if they have already checked or not. All right? The reason why we want you to do it and you come and do it here is because not just that we know, we want to provide counseling for you, whether it is positive or negative. If it is positive, then you need to start your luteal support. And if it's negative, then we will counsel you and schedule you for 2 weeks for a more detailed counseling to know what happened and what the next stage is. Every woman, every couple that goes through IVF here that doesn't get pregnant, we do a review right here in this hall. All the team will come together and we'll do a presentation, and we're asking ourselves, why did this patient not get pregnant? And we try and review and say, okay, this is what could have happened, this is what could have happened, this is what the patient has. And then, so when we're discussing with you 2 weeks afterwards, we are more informed. We already have gotten a report from the embryology lab as to their own report and the process. So we know what to do. Now, I want to say that the journey to parenthood is actually a journey. Why we trust God that every couple who starts a program achieves pregnancy that first time. The reality is that not everybody will achieve pregnancy the first time, because that's just the way it is. Human reproduction is not 100%. And that is why, even for super fertile couples, 25% to 30% of them will only get pregnant in that circle. As they keep meeting, the number of times they're getting pregnant, the percentage of the probability of getting pregnant will increase. What am I saying? And that is why you notice in our programs, we usually don't encourage one circle program. We encourage more than one circle. So even in our foundation program, we do a 2-circle program, and then you pay additional cost as the case may be. Or if you are coming through the regular program, we have 1 circle, 2 circles, 3 circles. Why? Because we know that in fact, 50%, if 50% of patients get pregnant in one program, that is a very high success rate. Because imagine we are doubling what the natural body is doing. 25, 30, then you say 50%, that is a lot. But what we would do is to ensure that we give you all the necessary attention, give you the best of care to try and ensure that in your first circle, you have a good opportunity of achieving conception. And then 2 weeks after, when you come in for your pregnancy test, next slide, we expect to see 2 lines. I will tell you, congratulations. If we say congratulations, you go ahead to start off your luteal support. Let me say it now for everybody, okay, and those who are listening who are online. After you have been confirmed pregnant, your luteal support starts immediately. Terms and conditions will apply. And we know what that terms and condition is. 300,000. 300,000 only. No other things, I don't mention the money, but this one I have to mention it because a lot of patients have said, oh, I was not told. No, that's why I am saying it. 200K. What is that 300K for? It's for all your medications that we use for the next 6 to 7 weeks to support the pregnancy until you get to 12 weeks. All right? And if it's negative, you will be counseled, you'll be encouraged, and then we will book an appointment to see you in another 2 weeks to discuss and explain why the outcome was like that. All right? But the assurance we have is that for almost all patients who come in desiring to have their babies, as long as they are not willing to give up, and they have what it takes to continue on this journey, almost everybody will come back with their babies. Almost everyone. And so, on this note, I want to say thank you very much for coming. And at this time, I want to take questions, if there are questions, or if there are comments. I want to take comments. All right. Thank you. So, questions? Yes, sir?
You mentioned something about sharing, investigating, and the root cause of the behavior crime, and share with you. I'm sure I get it my platform. But going back is not the issue. What is the root cause? I think there must be an investigation. And from this, we can never think what to do or what to prevent further in case of my revelation. But I haven't finished about this report.
For a lot of those discussions, it's not necessarily an investigation that we are conducting. What we are doing, we are examining the reports. For example, what affects success can either be due to the embryo. That's one major factor. The quality of the embryo, which is a function of the quality of the egg and the sperm. And two, the carrier, the womb. And so if a patient doesn't get pregnant, we're looking at the quality of the embryos. Embryos are divided into quality. You have grade A, grade B, grade C, grade D. A grade B embryo can implant, just that the chances are less. A grade C embryo can implant, so that the chances are what? Are further less. Grade A has the best chance of implantation. So if we have a grade B embryo or a grade C, the question we're asking is that why is that embryo not a grade A? It's a function of the egg and the sperm. And then we're looking at so we now go back and say, okay, if it's a self patient that she used her eggs, we're asking, what is the age of this woman? We already know women based on their age who go ahead with stimulation, what the outcome will be. So when we see the outcome, we are not surprised. It is those that we did not, it wasn't supposed to go through that route. For example, a woman that is 32, that was 30, that is 30, we expect the quality to be okay. But if it doesn't come out fine, we're not looking at the egg itself. We're also looking at the quality of the sperm. Because egg and sperm, they compensate themselves. A woman that is 35 and has a husband's sperm that is fantastic, the outcome will be better than somebody who is 35 and the sperm quality is average or low. Again, a woman who is 32 and the quality of the sperm is terrible will be worse than the woman who is 34 but has a better sperm. So we will look at all of that. And if we think that, oh, the husband's sperm, there was an issue, we'll ask you, repeat the test. Or before you even repeat, we would already have gotten an idea from the initial test you did. And then we'll ask you, start off medication, supplements, and then let's repeat this test after 2 months and see if there's been an outcome. Now, if we had very good embryo, that means the issue is not with embryo. Because with experience, we've come to know embryos that should implant. Bearing any factor, this embryo should implant. If it doesn't implant, then we know that it's not likely it's the embryo that has the issue, it's the womb. So we're asking ourselves, does she have fibroids? Again, the issue of fibroids and how it affects implantation is not a very straightforward thing. Why? Because there are patients who have fibroids and get pregnant, right? And there are patients who have fibroids and don't get pregnant. And so when we look at the woman who has fibroids and she doesn't get pregnant, and the embryos are good, then we now start telling ourselves, maybe it is because of these fibroids. And depending on the location of the fibroids, the size of the fibroid, and the number, we will counsel that this woman should have surgery. Now, you don't need to do any test to do it. We already have known that this was a factor. But and there are some patients we will tell, they are fibroids, so we are not sure whether this will be a challenge or not. Sometimes we may think it may be a challenge, and then the woman goes and gets pregnant. And what I know that most women don't want to go through fibroid surgery. I mean, once you just start, say, no, doctor, please, if I give you two options, try first. You have fibroid, so try first, and let's see. If you don't get pregnant, then we'll remove the fibroid. Or let's remove this fibroid now. What would most of you there pick? Try first, exactly. Try first. And so we try, and we have very good embryos, and there are fibroids. Then we say, okay, now it's time, let's take out these fibroids. But there are also times where we will do it. That's why you notice that after each test and the woman is negative, we will always want to do a scan. Because one of the factors we've also found out that is responsible for women not getting pregnant is development of fluid. Suddenly, this woman just had fluid developing in her womb. It wasn't there before. Some may not even have had it during the course of stimulation. On the day of transfer, you notice that you are scanned because we do the transfer under scan, under ultrasound guidance. You have a transvaginal scan before we start, and then you have an abdominal scan while the process is on. No fluid. Some people may have had fluid before it was drained and then the place was dry, but after the transfer, they develop fluid. If there is fluid, then that is the reason why conception did not take place. Now, there are some, endometrium is fantastic. Just like what I showed. Embryos, fantastic. But yet this woman did not get pregnant. Now, when we have such scenarios, we start looking at natural killer cells. There are probably antibodies. There are cells that are fighting the embryo, killing it from developing. Now, that is when we may need to do tests. But those tests are very invasive. You need to now bring the woman, take to theater, collect biopsy from the womb. And so we say that if the treatment for that is to give steroids, why not just do it prophylactically instead of taking that woman through all of that process to try and diagnose that this is actually the reason why. And a lot of labs don't have that capacity to be able to do that. And so you notice that once a woman has gone through first time, second time, and we're not able to pinpoint what exactly is the cause, we will tell you in your next program, we will give you steroids. There are some of them would say, this womb, the way it's looking, it's not really very clear on transvaginal scan. Let's do hysteroscopy for you. Then we'll say, okay, let's schedule her for hysteroscopy. So those are the things that, so some people may not necessarily have a particular test that is done for them. It's just based on the reports that we get, how we interpret the reports, and what we've decided to do. In fact, there are some people who will decide that, no, this protocol we used the last time may not be the best for them. Because we realized that when we use this protocol, the levels of progesterone was high. Let's use another protocol. You understand? So for your own particular situation, I'm not sure what exactly, but I'm sure that we would have had some discussion at the point of counseling after I feel that if after I failed the IVF program, to say this is what we're going to be doing next. So that is noted. Goes through its 2 weeks post-pregnancy scan counseling. No, post-pregnancy test counseling. So at that time is when we tell them this is what possibly could have been the reason why. Okay. Any other question? No other question? He said that you understood this thing very well. I just confused all of you. Did we understand it? Please go ahead. I mean, yeah. Down regulation. You understand? I don't know if you came in a bit late before we were here. Yes. So we talked about down regulation. For a woman who has been properly down regulated, LH will not have any effect. Hormonal imbalance will not have any effect. All right. If at all a hormonal imbalance will have an effect, it probably will have an effect on the quality of the egg, because that is something that has happened before we even started. The quality of the egg. For example, if a woman is polycystic and she has very high levels of LH, all right, and then she has hyperandrogenism, because of that high levels of androgens, it also has affected the quality of the eggs. But once we know that, again, the protocol we use changes, and the medications we use and how we use it would also change. But it doesn't, based on what we are doing right now, right there, affects, hormonal balance doesn't affect, because we take care of that already. Yes. All right. Any question from our online audience? Okay. So usually we tell the men that at least 3 days abstinence is fine. 3 days. And the reason why we're doing 2-3 days is because we want to be able to build volume. Okay? We want to be able to build volume. But let me state this. For patients whom we have counseled you and we said, the motility, the sperm motility is very low. Because I know there are some men that say, woman, don't just come near me. I'm building up. You know, I have to come and produce so and so times. I want to gather the team. For women, for men who has issue with low motility, that will be it will not be a positive, yes, to be counterproductive. Why? Because for sperm counts that have low motility, it means that their viability is also low. It therefore means that they die often. They don't last. And so if you're not ejaculating, you are just storing what has been there. On the day of transfer, yes, you will have the volume, but most of the sperm cells will be dead. Yes. And once the sperm cells are dead, then there's no use. So for men who have issues with the sperm motility, we ask them to meet frequently, to ejaculate more often. If possible, every day or every other day, just make sure you are ejaculating. Then just give 2 days space just before you come in for the production, just to have volume. That way you would have released most of what has been stored. Remember, the way this sperm, this male reproductive system is that whatever is produced first, yes, is what goes out. So imagine you have produced that and you've not done anything. It has just been there and it has died. When on that day of production, that is what you will release. And that's why sometimes the embryologist will look at what you have produced and they tell you, produce another one. And sometimes when you do that, the second one is now better than the first. Okay? So 2-3 days is enough. All right? And then just to also note that the means of production of collection of the sperm is through masturbation, not coitus interruptus. Not because why? Because if you do that, contaminations are very high. And once there's contamination with the vaginal secretions, the vaginal secretion has a lot of bacteria. Once it contaminates the process, that is the end of that program. All right? So please, it's very important for us to note this. And if that is a challenge, let us know. Again, if it's difficult for you to produce outside your area of comfort, or if you have difficulty generally with production, let us know. Why? Because we've had situations where the day has come and the man could not produce. And if you can't produce on that day, that is the end. Because we cannot keep the eggs for a longer period, for a long period. All right? So please, it's important for us to know so that we can plan ahead. And what are some of these plans? We can ask you to come, produce and freeze. Let's have a backup. So if on that day, nothing happens, we know that we already have sperm that we have frozen that we can use. Okay? Some people have the issue of once it's not their house, nothing can happen. Once they're coming outside their home, we can look at those peculiarities and even ask you to even produce at home, give you the container, produce, and then bring. Okay? Let us know. Okay, so there's some questions here. Okay, let's look at the online questions. Huh? Okay, well understood. Okay, they don't have any question. Okay, so no questions. So at this time, we just quickly want to just do a very short survey. So the nurses will just share a paper to everyone. I think it's one for each couple. So if you're a couple here, you can just have just one out. You fill it just to fill out and just hand over to us. We just want to just get a feedback.
We that we are online, how can we get our own?
That is no. For those who are online, we can have an online version now, right? So
yes,
for those of you that
yes,
are online, yes. Sorry for that. Sorry about that. So we will get the form across to you. Okay.
Okay. Thank you very much, sir.
And then you will send it to our email.
Okay, sir.
Thank you very much.
Excuse me, sir. I don't know. I have a question.
Please go ahead.
Okay. My husband is not in town.
Okay.
And if we are asked to come for the production of the sperm, and maybe we'll meet maybe 2 weeks before he comes, and that day that is to produce, he comes a night and we can't meet because he has abstained. I don't know if he can produce the sperm the next day that they ask us to come.
Sorry, if I get the question correctly, your husband is not in town?
Yes, sir.
And he comes in a night before?
Yes, sir.
So you're asking if
and we did not meet, hoping to meet to give his sperm the next day in the hospital. Is that fine?
In the hospital? Where we would prefer, it depends on what the state of the semen parameters are. If everything is fine or average, there's no major issue, we will prefer you wait, don't meet, and just let him come the following day and produce.
Okay, that is, he has stayed for 2 weeks without meeting.
2 weeks? Yeah,
yes,
like I said before, if there is no challenge, because the issue we raised had to do with men who have very low motility. If there are no issues, yes, it should just come. The reason is because if you meet the next day, he may not, yes, the day before you meet, the next day, the volume that he produces will be very small. All right? Okay. So it's safer for him to come and then produce on that day.
Okay. Okay.
Thank you.
Thank you, sir.
You're welcome. Pen. She needs a pen.
Sorry, sir. I don't know. They will send us our own online. Is it today or tomorrow?
Today.
Okay. Okay.
Yes. Please go ahead. The success rate depends on what caused the reason why the first one failed. If it's something that can be corrected, all right, then the chances are increased. But if it's something that cannot be corrected, then it's basically the same probability. For example, we did a first circle and the challenge had to do with the quality of the egg. If that factor has not changed and we do a second circle, it will still be the same thing. But if that factor changes, and for example, the woman now decides that, okay, let me opt for an egg donation program, then that increases the chances of success. If the reason why it failed was because of poor embryo quality because of the sperm factor, and the man has been on supplements, and that helped the quality of the sperm, then again, in the second circle, there will be an increased chance. So if it's for both, that means an embryo donation, right? That's what you said. Embryo, that is both is donor, right?
Yes.
That is embryo donation. Again, we need to look at the reason why the first one failed. If the first one was failed because of poor quality embryo, remember, and let me just say this. The fact that we are using an egg donor that's of a younger age does not 100% of the time mean that the quality of egg will be super, will be very good. Experience has taught us that sometimes when we collect eggs from young donors, that the quality isn't as good. So if we notice that the issue had to do with the quality of the egg, the next time we will change the donor. And hopefully that should give us a better outcome. But if the embryo quality is good and it failed, then we're looking at the womb. All right? So like I said before, if the lining is good, there are no fibroids. So what we do is the second time, we'll assume that they probably have natural killer cells. And so in the second circle, we would treat for natural killer cells by giving steroids. And quite a number of them have gotten pregnant in the second circle. All right? Have I answered the question? Good. Okay.
In a situation whereby dropped in from in the first circle, the problem was with
for the what? Nobody's responsible for the failure. No, it's a very good question because the truth of the matter is this. Now, from the side of the patient, I'm sure you will think that the hospital should bear the responsibility. Now, but we are saying that we can't bear the responsibility. Why? Because we can't determine whether a donor would produce good quality eggs or poor quality eggs. We can't determine it. There's no test that can determine that. The only factor that determines quality is age, and we've gotten the age right. But we are saying that even with age, there are some there are some donors that don't give us a good outcome. And so once we see that, we know that it is the donor that is responsible. Now, sometimes it could be both donor and sperm. Why so? You have a donor that is average, and then you have a sperm that is very good. That sperm would compensate, and then you have a good embryo produced. But if the quality of the egg, of the sperm is not good, and you have an average donor, the embryo quality will not be good. The ICSI is just to achieve fertilization. The ICSI is not to bring about a healthy embryo. The ICSI is to increase the rate of fertilization. Because when we are doing ICSI, as intracytoplasmic sperm injection, we are taking the sperm and injecting it into the egg. Yes. Now, the ICSI doesn't pick quality sperm. It picks a sperm that is moving based on what you can see, because there are certain things that you cannot predict by just you doing ICSI and picking quality sperm. For example, DNA fragmentation. You cannot pick that on by just looking at the sperm under the microscope. You understand? Even when you are doing ICSI. So, yes, you can try to see a sperm that is very active and use that to judge that this sperm may be likely quality, but is not absolute. But the aim of the ICSI essentially is to increase fertilization rate. But what the outcome of that would be is not determined by the interaction of the sperm and the egg. Now, if we have embryo, now this is what we do. For a woman who is going through a recipient program, and on the day of transfer, we looked at the embryos, and the embryos quality is not viable, we will not do a transfer. Yes, I need to state that. If we think that the quality of the embryo, if we think that you don't have viable embryos, we will not do a transfer for you. We will call you in and we'll tell you that, sorry, these embryos, they're not looking good. If we transfer them, you will not have a transfer. We're not talking about quality. You can transfer a grade B and the patient will get pregnant. We're talking about viability. There are embryos that we know, that we see. No matter if we transfer them, you have a 0, not even 5. We have a 0% chance of conception. We will not transfer. Now, when that happens, the decision we take in terms of monetary implications differ. And what we've done here is to try and do more like a sharing. For example, if you paid for a 2-cycle program through the foundation, and you are doing your first cycle, and you've done the first cycle, and we get to that point where, oh, we can't do a transfer. The program has come to an end. We've generated embryos, but the quality of embryos are not good, so we can't do a transfer. Ordinarily, you should pay for a second cycle, additional cost, and then we'll do it. But what we do is to tell you that we'll do the second cycle, but you won't make payment. All right? We run your second cycle, but no additional payments. Now, if that is your second cycle, maybe you did your first cycle, did transfer, there was no pregnancy, and then we are doing your second cycle, and we get to that point where we are seeing this. What should happen is that program has come to an end because you've had 2 cycles. So you're supposed to make, if you are coming through the foundation, make payment for the main program, 2 cycles, and pay an additional cost for the first program. But what we will do is to now extend that program with a 3rd cycle. And for that 3rd cycle, you need to make payments. So it all depends. So we take the burden of the main program from you, offer you a 3rd cycle, and ask you to just make the additional payment for it. So what we do is that we share the burden depending on on which program you are on. Okay? So for those of you who are on the recipient program, one prayer point you should pray. Lord, they want to hear the prayer point. They want to hear the prayer point. Lord, cause my donor to produce quality egg. That's a very solid prayer point too. I'm telling you, cause my donor. Because the truth is that we can't tell which donor can produce good and bad quality. That's the truth. We can't tell. And there are some donors we have used before, and we say, oh, this one is a donor. And then let's use that again. And this time, what happened? Quality happened. Because you're not seeing it, so you're asking yourself, what happened? Why is it like that? But when quality goes well on both sides and you produce very good embryos, you have a more than 70% chance that you'll get pregnant. All right?
So there's no way to determine the quality of the function.
For the egg, there's no way to determine. It's just age that determines. Quality of egg is a function of age. The function of age. But we know that patients have different body types. So you have variations. So some people will go beyond the normal range. That's just life. And we can't tell this one. We will use we are very, very, very selective. We don't use, once you don't meet the standard, we don't enroll you. But even with that, I'm saying that even with that, we still do have occasions where we say, I think the egg is the issue. And when that is the issue, we will let you know, and then we would. Of course, we won't use the same donor the next time. We use another donor, and then hopefully we get a different outcome.
Amen. Amen. Amen.
So for patients who are coming through the foundation, for IVF is 5 eggs, for ICSI is 7 to 8 eggs. Why? The aim is that the aim for, as I mentioned, those coming through the foundation, because those are our special programs. We aim to have 2 or 3 blasts generated, not more than 2 or 3. You have 2 very good embryos, you're good. Your chances are very high. Oh, you have 3. Even when we transfer 3, in my mind, I'm telling myself, this woman should just implant. I don't want wahala. I'm telling you now, that is my prayer. You may have your own prayer, but that is my own prayer inside me. I say, Lord, we are transferring 3, but let 2 implant. You know why? The stress of 3 is not a joke. Abroad, it's only one they transfer. I'm sure for those of you who have had to do this in abroad, in Europe, it's only 1 embryo they transfer. You won't transfer 2. Where? You know why? They are scared of multiple pregnancy. The challenge of care of multiple pregnancy, ICU, NICU care, neonatal intensive care is very expensive. The cost you spend to take care of a preterm is times 10 the cost you use to pay for IVF. So they don't want to. But my people, yeah, they okay. Who for? What are you doing with this? What are you doing with this, Lord? Doctor, you don't understand. I've been this journey 10 years, 15 years. I know, but again, we're also careful of your health. No, we often say that if you carry 1 and you deliver 6 weeks, you are back to your pre-pregnancy stage. If it's twins, 3 months, you are back 6 months. If it's 3, you don't ever get back home. You don't ever get back because your life has entered into another phase, another jar. Taking care of 3. It's not a joke. So to answer your question, 2 or 3 is what we aim to transfer. So therefore, for patients who are coming in for IVF, recipients 5 eggs, and those who are for ICSI, 7 to 8. Of course, we do. Of course, so when we say, she asked the number that we give, so I said, now with that, there are patients who will give 5 and all the 5 will make it to blast. I won't transfer 5, no matter what you say. I will never transfer 5. We'll transfer 2 or 3, then we'll freeze the remaining one. All right? Yeah, so we have facility for freezing. Now, for patients who are coming through the foundation, the freezing is covered. Freezing and storage for 3 months is covered in your main program. But after 3 months, you need to pay for storage, which is 10,000 monthly. Terms and conditions would apply. All right. So let's say, for example, we did a transfer and then you got pregnant. So you still have embryos with us. After 3 months, you need to start keeping that embryos for storage. So when you are done, you come back and come and collect the one that have been frozen. Okay. Okay, this.
Can you take after the night? Can you just take what anything?
When it comes to food, like I said, the only thing that is off the table is potash. Maybe that thing, it doesn't affect. Just ensure you eat healthily. All right, fruits, vegetables, all in different. What kind of fruits? And the foods that are common to you that you know. You don't need to start going to buy anything that you're not used to. No, people are used to different fruits. It can be carrots, it can be pineapple, it can be oranges, it can be watermelon, it can be cabbage, it can be grapes, whatever fruits you're used to taking, it's fine. And then lots of vegetables. Okay? Any other question, comments? Okay, so on that note, on behalf of management and staff, I want to thank every one of you and to most sincerely wish you a great outcome as we go through your program. Let's be very prayerful and let's just trust God. And then I believe that all of us here will all be confirmed pregnant, and then you'll be on your journey to having your babies. Okay?
Amen.
And then for men that came, thank you very much. I salute you. We had 1 initially, then 2 added, but now we have, 1, 2, 3. Oh, fantastic. Good. Well done. So have a wonderful weekend. Have a nice day. How are you? Hello there. How are you? You'd have shared these things since now. Why not put them inside nylon? I'll just give them to them like that. You package this in very well now. What's wrong with you guys? Well done. Everything went well? Good, good.